Good morning everybody. I am Dr. Nitin Joshi Professor in Urology with teaching experience of 25 years, working as consultant neurosurgeon in Panvel. Today we will discuss controversies with androgen deprivation therapy with Flutamide withdrawal syndrome. In the theory and practical, there is a lot of weightage regarding the androgen deprivation therapy and hormonal therapy. The examiner will be asking many questions related to androgen deprivation therapy, and so the controversies related to androgen deprivation therapy has to be very clear. The androgen deprivation therapy has become the cornerstone for metastatic cancer prostate and advanced cancer prostate. However, the chronic or long-term androgen deprivation therapy is associated with many comorbidities like hot flushes, gynecomastia, sexual dysfunction, cognitive dysfunction, skeletal related events, cardiovascular events, and so there are various controversies regarding the androgen deprivation therapy. And the first controversy is whether the patient should be given minimal androgen blockade with anti-androgen monotherapy or castration. Now the concept that is minimal androgen blockade with the anti-androgen monotherapy, it was studied with the biglutamide, and that also with a high dose. Routine dose of biglutamide is 50 mg, and it has been studied in young sexually active male patient, and the group was locally advanced cancer prostate. The concept was that the patient is young, sexually active, and if there is a castration, then because of fall in the testosterone, there will be sexual dysfunction affecting the quality of life. And so the study of the biglutamide in high dose of 150 mg per day in young patient with the monotherapy, the study has shown, one of the study has shown that if the patient is subjected to the monotherapy in case of the advanced prostate cancer but no metastasis, then the one study has shown that the efficacy of this high dose monotherapy anti-androgen with biglutamide is equivalent to the LHRH agonist, that is medical castration or surgical castration. However, if the patient is having metastatic cancer prostate and the patient is subjected with only with the anti-androgen monotherapy, then it is inferior with respect to the cervical benefit. So the overall survival is lower with the anti-androgen monotherapy, and hence FDA has not approved the concept of the anti-androgen monotherapy because of high cost as well as because of inferior result with respect to the overall survival as compared to the castration in case of metastatic cancer prostate. Now the next controversy is if the castration is surgical castration or medical castration. Now the advantages of surgical castration is that it is safe, reliable, it is effective, it is cost effective, that is economical. And with the surgical castration, the castrate level of serum testosterone, in fact lower than that, that is even less than 15 nanogram per ml, is achieved in less than 1 day. The studies have shown that it mean time to fall the testosterone less than 15 nanogram per ml is even 8.3 hours. That is very fast, and so this treatment is advocated in patients who has got advanced cancer prostate causing the complications or consequences of this advanced cancer prostate, particularly if there is impending cord compression because of extensive mets in the spinal column, or if there is impending pathological fracture because of extensive bone metastasis, or impending acute renal failure because of possibility of obstruction of both ureters due to extensive retroperitoneal lymph node disease, or because of the involvement of the trigone because of upward progression of locally advanced cancer prostate. So this considered as the standard treatment, and with the results of all other treatments are being evaluated with respect to the surgical castration. So the patient is able to achieve the castrate level very fast, it is very reliable, it is very effective, and so the treatment is the treatment of choice, particularly when there is emergency, so as to avoid the catastrophe. The proponents of medical line of treatment suggest that the newer drugs, that is those which are Gnrh antagonists, which inhibit the Jnrh immediately, like injection degarelix, also can achieve the similar effects. However, the castrate level is achieved with the degarelix in about 24 to 48 hours, so not as early as surgical castration. And always there is a question of availability, cost, and the side effects of the medication. Now regarding the disadvantages about the castration is that this patient, once there is castration, there are 3 P's, that is, it is the psychological effect, physical effect, that is trauma, and third, that is the permanent. So psychological trauma is that feeling of the losing one's manhood forever because of loss of testicular sensation. So it is suggested that in this loss of testicular sensation, which is because of empty scrotum, which is seen in standard orchiectomy, so instead of subjecting standard orchiectomy, subjecting to subcapsular orchiectomy, where removal of all testicular parenchyma, hence interstitial cell of Leydig, which is the source of testosterone, but keeping tunica albuginea, and hence the patient gets the feeling of testicular feeling, and hence there is no empty scrotum. As a result, the psychological trauma will be less. Now the studies have shown that regarding the efficacy, question regarding the cost as well as efficacy, the studies have shown that if the person is subjected to medical castration with the LHRH, there is no survival benefit as compared to surgical castration. Also, the studies have shown if the patient is subjected to LHRH agonist injection depot with the leuprolide acetate or goserelin, then if the life expectancy of the patient is less than 3 months, then it is cost effective. But if it is the life expectancy is more than 3 months, that is, if the patient requires to give second depot injection, then LHRH agonist treatment, that is medical castration, is costlier as compared to surgical castration. And so in efficacy wise as well as in the cost effectiveness, surgical castration is superior than the medical castration. Now if the medical castration is required, then there is again a controversy whether the Gnrh agonist or Gnrh antagonist. Now the pharmacological basis of Gnrh agonist is that normally, that is physiologically, endogenous hormone Gnrh, that gonadotropin releasing hormone, is synthesized by the neurosecretory cells of hypothalamus. This Gnrh is carried from hypothalamus via hypothalamo-hypopituitary portal circulation to anterior pituitary. This secretion is in pulsatile fashion. So the Gnrh is carried to anterior pituitary in pulsatile fashion. At anterior pituitary, the pars positive gonadotropes having Gnrh receptors are stimulated by the hormone Gnrh in pulsatile fashion. Due to stimulation of the gonadotropes, the secretion of FSH and LH in pulsatile fashion. The released LH is carried to the testes to stimulate the interstitial cell of Leydig to secrete testosterone. But when the Gnrh is given in synthetic form, then there is a chronic and continuous stimulation of the gonadotropes of anterior pituitary, and due to continuous and chronic stimulation, there is downregulation of the Gnrh receptors present on the gonadotrophs of anterior pituitary. This results into, rather than stimulation, inhibition of gonadotrophs, resulting into the no secretion of LH. As a result, there is no secretion of testosterone from the interstitial cell of the testes, and hence there will be castration. So these Gnrh analogues, they are synthesized by substitution of amino acid in the peptide, particularly the 6 amino acid level. These synthetic analogues have got more affinity for the Gnrh receptors present in the anterior pituitary, and hence their efficacy as well as the half-life is longer than the endogenous. So it can be given as a depot form. But the disadvantage of the Gnrh agonist is that in the beginning, Gnrh agonist stimulates the gonadotrophs, resulting into LH surge and hence testosterone surge, causing the clinical flare phenomena. That is, because of increased testosterone level, there will be progression of disease, that is proliferation of the tumor cells, causing deterioration of the symptoms as well as progressive increase in the serum PSA. So, in order to prevent this clinical flare, this particular Gnrh has to be combined prior to giving the Gnrh with the anti-androgens. The anti-androgens are usually combined as non-steroidal anti-androgen. They are flutamide, nilutamide or biclotamide, and they should be started 1 week prior to Gnrh and should be continued for about 3 to 4 weeks after giving Gnrh. This is because when you give the Gnrh, that time to achieve the castrate level, it takes about 3 to 4 weeks, and so to cover up this period, the patient requires the addition of anti-androgen. The rationale is that when there is Gnrh agonist is given, initially there is LH surge, testosterone surge. This will result into proliferation of the tumor cells and progression. But the anti-androgens, they will inhibit the effect of the testosterone secreted from the testes as well as the weak androgens from the zona reticulosa. As a result, the progression of the disease and clinical flare will be inhibited. So, Gnrh agonist, where patient is already having advanced cancer prostate, should not be given alone when there is suspicion of one, that impending cord compression, impending acute renal failure because of ureteric involvement, bilateral ureteric involvement because of extensive retroperitoneal lymph nodes, or possibility of the pathological fracture because of extensive bone mates. So the addition of the anti-androgen prior to Gnrh agonist and 3 to 4 weeks after Gnrh agonist is mandatory. Also, Gnrh agonist injection, patient, the costly it is, if it is more than 2 depots, it is always more costly than the surgical castration. Now the next, that is whether the patient can be subjected to Gnrh antagonist. These are the newer drugs which have got totally antagonistic action on the Gnrh receptors present on the gonadotrophs of anterior pituitary, where the Gnrh receptors are blocked immediately and competitively. This results into inhibition of function of the gonadotrophs, that is inhibition of secretion of LH, resulting into inhibition of secretion of testosterone, and hence castrate level can be achieved after giving Gnrh agonist within 24 hours. So even these drugs, that is Gnrh agonists like injection Degaralex, are the drug of choice when there is advanced cancer prostate and to prevent the complications where you suspect that impending cord compression because of the mates in the spinal column, or impending pathological fracture because of extensive bone mates, or impending acute renal failure secondary to involvement of both the ureters. due to extensive retroperitoneal lymph nodes, then injection degaralex can be given. However, it takes longer as compared to surgical castration. So if the patient is unfit or unwilling for surgical castration, and if the drug is available and the patient is affording, then only the injection degaralex can be given. The advantage of this drug is that being it is purely antagonistic, so it causes immediate inhibition of gonadotropes. As a result, there is no LH surge, no testosterone surge, and so there is no clinical flare phenomenon. As a result, the co-administration of anti-androgen, which is required for Gnrh agonist, is not required. But disadvantage is that that first generation and second generation Gnrh antagonist like Aberalex, they have got the systemic allergic response because of histamine release, and there is always the problem of the cost and the availability of the drug. Now next concept, that is whether the castration alone or combined androgen blockade, that is CAB. It is not complete androgen blockade, but it is a combined androgen blockade. It is concept of addition of the anti-androgen steroidal or the non-steroidal anti-androgen to castration, that is surgical or medical castration. This is because castration removes source of testosterone only from gonad, and so if after the castration, if there is progression of disease, that is castrate resistant prostate cancer, then it is due to secretion of weak androgens from the zona reticulosa of adrenal cortex, which can be taken care of by these anti-androgens. Because these anti-androgens, they compete with the androgens from the gonads as well as extra gonadal sources at the androgen receptor, as a result of which there is no transcription, translation and synthesis of proteins, and so there will be no further progression of the disease. In the past, whenever the patient of advanced cancer prostate or metastatic cancer prostate, immediately or the early institution of combined androgen blockade was instituted. But studies have shown that if the patient of advanced cancer prostate is subjected to combined androgen blockade immediately, then such patients, one, because of addition of two drugs, compounding the toxicity of two drugs, then increasing the cost of the therapy, and third, increased incidence of progression to hormone refractory cancer prostate is possibly high. Also, increased incidence of Flutamide withdrawal syndrome. Also, the studies, there is no consensus after so many studies that the immediate institution of combined androgen therapy in patient with the diagnosed case of advanced cancer prostate is going to have any overall survival benefit. So, according to the guidelines, it is stated that if the patient comes with the advanced cancer prostate or metastatic cancer prostate, it is always better to go in a stepwise fashion. That is, it is cancer naive, that is not undergone any form of castration. There should be first castration, and then in spite of castration, if there is progression of the disease, that is, the patient has developed now castrate resistant prostate cancer, then only there should be addition of the anti-androgens, either steroidal or non-steroidal, so as to achieve a combined androgen blockade. The studies have shown that the combined androgen blockade is the most costly form of androgen deprivation therapy. So cost effectiveness wise, it is very costly as compared to only castration alone. So when it is really required, then only there should be a combined androgen blockade. Now, what is the concept of Flutamide withdrawal syndrome? Now, patient who is diagnosed to have castrate resistant prostate cancer and been subjected to combined androgen blockade, or patient has been already having the combined androgen blockade to begin with when the patient was diagnosed to have advanced prostate cancer. Such patients, because of not only castration, but because of the blocking the androgen receptors by even by zona reticulosa, in the beginning there will be improvement, that is there will be fall in PSA, there will be clinical improvement in terms of the symptoms, but in spite of the continuous treatment with the even addition of the anti-androgen, the patient may show deterioration in terms of biochemical progression and even the clinical progression in terms of symptoms. Studies have shown that such patients who are having CAB and castrate resistant prostate cancer, in this, if there is withdrawal, that is stoppage of the androgen from the treatment protocol, rather than the progression which one expects in progression of the disease, that is because of the cessation of the treatment, one expects that there should be progression of disease, the rise in the PSA, clinical deterioration, but paradoxically, rather than deterioration in the symptoms, if there is improvement in the symptoms, there is fall in the PSA, then it is the withdrawal syndrome. So the improvement, clinical improvement and biochemical improvement on withdrawal or the stoppage of anti-androgen from the treatment protocol of CAB is called as the anti-androgen withdrawal syndrome, or it is called Flutamide withdrawal syndrome or phenomenon. So it is initially found in the flutamide, so it is called Flutamide withdrawal syndrome. That is, on withdrawal of the treatment, rather than deterioration of the symptoms, improvement in the symptoms, there is disease not progress but improved. Biochemically PS has fallen down, and so this is called as the withdrawal phenomenon or withdrawal syndrome, and it is seen not only with flutamide but steroidal, all non-steroidal as well as steroidal anti-androgen. What is the mechanism of this flutamide withdrawal syndrome or anti-androgen withdrawal phenomenon? The mechanism is that normally when the androgen ligand is released from the gonad, it binds with the androgen receptor in the cytoplasm. It binds with the ligand binding domain of the androgen receptor to form hormone receptor complex. This complex is translocation from the cytoplasm across the nuclear membrane into the nucleus. During the passage, it gets converted by 5-alpha reductase into active form, and that is DHT. DHT has got more affinity for androgen receptor, and so now there is displacement of testosterone by DHT. So there is now DHT hormone with the androgen receptor. Now this complex moves inside the nucleus, where the nuclear binding domain of the androgen receptor binds with the androgen response element of the chromatin. This results into the transcription, that is formation of messenger RNA, which comes out through the nuclear holes of the nuclear membrane into the cytoplasm, where the messenger RNA along with transfer RNA and ribosomal RNA responsible for synthesis of structural proteins on the ribosomes, thus resulting into the proliferation of the cells. In castrate resistant prostate cancer, there is upregulation of the androgen receptor pathway. So there is overexpression of androgen receptor, overactivation of androgen receptor, and one of the mechanism is the mutation of an androgen receptor gene. That is, there is a point mutation in the androgen receptor. The mutation is at the point of ligand binding domain. As a result, here instead of ligand androgen, the anti-androgen binds, and after binding the anti-androgen with the ligand binding domain, this complex moves from the cytoplasm across the nuclear membrane into the nucleus, where in the nuclear chromatin it again binds with the androgen response element, resulting to transcription, translation, synthesis of proteins, and thus here the anti-androgen has got agonistic effect on the prostate cancer cell lines causing the progression of the disease. And so the cessation of the treatment with anti-androgen results into the regression of the disease, symptomatic improvement and fall in the PSA. The withdrawal syndrome, that is clinical improvement or improvement in the biochemical parameters, will depend upon the half-life of the anti-androgen. The half-life of Flutamide is 6 hours, and so it takes about 4 weeks after the stoppage of the Flutamide to see the improvement clinically and biochemically. Nilutamide, the half-life is 2 days, and so it takes about 5 weeks after the cessation of Nilutamide to show clinical or biochemical improvement. While the bicalutamide has longest half-life, and that is 7 days, and so it shows clinical improvement or the biochemical improvement after about 6 weeks. So the guidelines have been stated that if the patient is having the castrate-resistant prostate cancer and on CAB, then first step before starting the second line of hormonal therapy is always the withdrawal, that is cessation of the anti-androgen from the treatment protocol. After stopping bicalutamide or Flutamide, wait for 6 to 8 weeks to see whether there is a fall in the PSA, clinical improvement. If there is no fall in the PSA and no clinical improvement, then one proceeds with the second line hormonal therapy like abiraterone acetate with prednisolone, with or without enzalutamide, or chemotherapy. So in castrate resistant prostate cancer, it has to be a very orderly stepwise approach. Now the last controversy regarding the androgen deprivation therapy is whether early or that is immediate androgen deprivation therapy or delayed or late androgen deprivation therapy, because no one knows what is the ideal timing for androgen deprivation therapy. Now one spectrum is early androgen deprivation therapy, that is institution of androgen deprivation therapy when there is the first sign of primary cancer prostate failure, and late or delayed androgen deprivation therapy means there is the evidence of the distant metastasis. Now the metastasis may be the symptomatic or the asymptomatic metastasis. The most ideal and accepted androgen deprivation therapy, and that too immediate androgen deprivation therapy, symptomatic metastatic cancer prostate. However, studies have shown that if the patient is having metastasis but it is asymptomatic, and if there is early or immediate institution of androgen deprivation therapy, then the biochemical as well as the clinical progression is prevented. That is, these patients, because of preventing the progression of the disease, they can be prevented of the complications or consequences of the advanced cancer prostate like cord compression, pathological fracture, acute renal failure because of bilateral ureteric obstruction, or requirement for the channel TUR because of significant bladder outlet obstruction. However, in this patient also, where they are metastatic but asymptomatic, and here if there is early institution of androgen deprivation therapy, whether there is any benefit in terms of overall survival, really not known. The studies have shown that if there is early or immediate androgen deprivation therapy institution in the group of patients who are having localized cancer prostate and classified as low risk stratification, then they are not benefited at all, but they do worse with the early institution. Maybe they are progressing early to hormone refractory prostate cancer. And so in such group of patients, that is who are having the localized cancer prostate and classified as low risk stratification, then such patient early institution of androgen deprivation therapy should be avoided. Thank you very much.